All right, we'll go ahead and get started, everyone. Welcome to today's Yale Pulmonary Critical Care and Sleep Medicine Grand Rounds. Just a brief logistical announcement for our Zoom attendees. You'll be muted during today's presentation, but please participate in the question and answer session immediately following today's presentation by putting your comments and questions into the chat, and we will then read them to the whole audience. I'm really pleased today to introduce Dr. Andrey Zinchuk as today's Grand Rounds speaker. Andrey did his undergraduate degree at Lehigh University, where he majored in chemical engineering, and then went on to be an assistant scientist for Pfizer in their global research and development program for 3 years. Subsequently went on to medical school at the University of Connecticut School of Medicine, internship at Beth Israel Deaconess Medical Center, and then a brief stint as a neurology resident before his rebirth, spiritual awakening, and conversion to internal medicine, where he went on to preach to the converted as a chief resident there. And then we were extremely fortunate to recruit him to Yale for his clinical fellowship and research training. And he is currently an assistant professor in our section. Andrey really has become a model physician scientist and has integrated very cutting edge and compassionate clinical care with some groundbreaking clinical and translational research. His clinical work has focused on his directing our advanced apnea management program at the Yale Centers for Sleep Medicine, where he integrates pharmacotherapy, positive airway pressure therapy, and upper airway neurostimulation to treat some of the most complex forms of sleep disorder breathing that we have. It's called the Advanced Apnea Management Program, or AMP Clinic, which is apropos given that you're using AMPs to treat some of these patients with upper airway neurostimulation. And his research really directly follows from his clinical care. And what he has really done a nice job of taking some advanced physiologic measurements that were largely relegated to research laboratories to better understand the underlying physiology and particularly the non-anatomic physiologic traits of sleep apnea directly to the clinic and look at the clinical significance of that, better phenotype patients, and his work is really moving to targeting and developing novel treatment approaches for these very high-risk patients. He's received numerous honors and awards for his research, including the Patterson Fellowship, the Parker B. Francis Fellowship Award, a K23 from NHLBI. He last year won the James Scatrid New Investigator Award through the American Thoracic Society, and he has just received an outstanding score on his initial submission for his first R01 application as well. So please join me in giving Andrey a warm welcome to the podium.
Wow. Thank you, Clark, so much for such a generous introduction. And I remember being here 11 years ago and watching Dr. Yagi give a pulmonary critical care grand rounds on sleep medicine. And I said, man, I want to do that. That looks fun. And so thank you, Dr. Yagi, for all the mentorship and turning me on to sleep medicine. And so this is a slide that tells you how you can get CME credit for this talk. That number will also be posted in the chat, so feel free to use that. And so I'll do a brief introduction about what the talk is going to be about. We'll briefly talk about sleep apnea, what it is, and what CPAP is. Many of you know what it is, but what we'll do is look at it a little bit in a different light. And we'll talk about what are some of the causes of sleep apnea that go beyond the anatomical things that we generally think about as risk factors for OSA. And then we'll spend some time talking about how these physiological traits of sleep apnea manifest as phenotypes of OSA. And lastly, we'll spend a little bit of time talking about how these traits may then be used to select therapy for our patients and the vision for the future. But before I start talking about the science and the grant writing and whatnot, the first thing I thought when I was going to do research was going to be really fun to like crunch the numbers and plot things. But really, the funnest part about research, it's really a social engagement activity. And so I couldn't really do it without the people that are shown here. So you have Clara Yagi, my first mentor, primary mentor, and then Nancy Redeker, who's in the audience. Thank you for coming, Nancy, who is a nurse PhD researcher and has taught me a lot about patient-oriented outcomes. And then these two gentlemen down below are from the Brigham and Women's Hospital, Scott Sands and Andrew Wellman, who have done groundbreaking work in physiology that I'm applying. And so my job as an engineer is maybe not so much to discover things, but to apply them for patient benefit. And so I'm also grateful to work with wonderful colleagues and mentees. And here you see former sleep fellows, current faculty, and Naya, Munib, and Yuri, who are wonderful research collaborators and team members. And of course, collaborators in science, including Melissa, with whom we've done some circadian work in sleep apnea, Dr. Brian Koo in neurology, with whom we're doing a lot of work on periodic movements of sleep, Steve Baldessari with substance use, and then Dr. Yüksel Peker from Turkey, who also does work in sleep apnea and cardiovascular outcomes. All right, so let's talk a little bit about sleep apnea. So I want to give you a little view of sleep apnea from a perspective that we don't necessarily always get a chance to do. And so let's see if I can click on the, oh, that's funny. Pointer options. All right, here we go. So this is a drug-induced endoscopy of a young man with sleep apnea. What you see on this right panel is the base of the tongue, that's the white stuff. And as the scope gets advanced further, you can see the larynx. And so you see a complete anterior posterior collapse in this individual. And you can see that the airway is a fraction of a percent of what it normally is. And so the primary reasons for this have chronically been thought to be due to anatomical features like our musculoskeletal features or the degree of obesity in the upper airway and the neck. And so this is the same gentleman who is undergoing, and so this is the video of the same gentleman who is undergoing sleep endoscopy and is being treated with CPAP. And let's see if I can have my mouse appear. Oh, that's interesting. Well, so the beauty of this video that you cannot see, but I'll tell you about, is that when somebody gets put on CPAP, the upper airway opens. And the more you increase the CPAP, the more the airway opens. And so that's the whole principle of CPAP that was discovered in the 1980s. It has generated billions of income for 2 or 3 companies in the world, and has been the #1 therapy for sleep apnea patients. And you know, most of that it does is improve the anatomical propensity for collapse. But CPAP can be a savior for all, but not for others. So I'll share with you a couple of stories that have influenced my career. And the first one is of this 56-year-old man. He's an ex-Marine, and this is the guy that I met at my first clinic as a quasi-attending and as a chief resident at the VA in West Roxbury. And he came to see me because he had otitis media, and it was not infected. It was serous. There was nothing going on, but he really wanted antibiotics. But then as I'm looking through his chart, I see that he's not sleeping. He has a diagnosis of chronic diaphoresis, which is only thing that you could see at the VA, and then has severe OSA. And so I engaged in sort of bribery, medical bribery. I said, okay, I'll give you 3 days of amoxicillin if you wear the CPAP device. And so he did, and he came back to see me 2 weeks later, and he was like, oh my gosh, doc, the CPAP saved my life. He's this Boston guy and had this beautiful accent. And he's like, I can sleep for 4 hours uninterrupted, and I can enjoy my dog. This is amazing. And so my nucleus accumbens had all this dopamine firing, and I was like, I want to do that again. So that's what interested me in sleep medicine in the first place. And then as a fellow here in the sleep clinic, I saw this 58-year-old woman. It was an executive, had these comorbidities, and had a similar sort of sleep presentation where she could only sleep 3 or 4 hours, continued to wake up at night, and more or less the same severity of sleep apnea by the AHI. But her outcome was very different. So she tried CPAP multiple times. Had tried a bunch of different masks and seen a bunch of different doctors. And like when I put the CPAP on, I just feel worse. I feel worse with it than I do without it. Can you help me? And so this really was a catalyst for me trying to think about, well, why is this person that way? Why is this difficult for her if she has the same disease as my other patient from a few years ago? And she's not alone. CPAP adherence, tolerating CPAP is really hard for patients. So what you see here is data from the SAVE trial. SAVE trial was the largest randomized clinical trial of CPAP for cardiovascular disease prevention, secondary prevention. And this is in a clinical trial setting where we do everything we possibly can to help patients use CPAP. And even in this best case scenario, the average adherence was 3.3 hours per night. Most people sleep more than that. So that's really, really hard. And the other challenge with CPAP is that, after we've identified the sleep apnea as a risk factor for heart disease, stroke, you name it, when we try to reduce the risk of it with CPAP therapy, it turns out that we haven't been able to show that. And this is just a list of all the randomized clinical trials looking at CPAP as a treatment to reduce risk of cardiovascular disease, to improve outcomes that are neurocognitive. And all these trials have been negative, and people are trying to understand, so like, why is that? And so there's a bunch of different explanations, but the thing that we've been thinking about for the last 5 or 7 years is that, well, perhaps similar to asthma, heart failure, and other chronic conditions, sleep apnea is also a syndrome. Maybe it's not really a disease in itself. And so it has heterogeneity in terms of pathogenesis and heterogeneity in terms of manifestations of phenotype. And this heterogeneity contributes to the risk of your consequences like cardiovascular disease, your ability to tolerate CPAP therapy, to adhere to it, how much you're able to benefit from CPAP therapy, or how many residual events you have on this device, and does it actually change outcomes like blood pressure, neurocognition, and anything of that sort. And so we've done some work, especially with Clara in our early times, where we looked at this phenotypic relationship to cardiovascular disease, and we won't talk about much of it today. So I'm really going to focus more on the pathogenesis and what we call the endotypes and how they might influence these other outcomes. And so let's talk a little bit about this physiology. I think in the sleep world, we're sort of starting to become used to some of this new pathophysiological causes of sleep apnea, but they may not necessarily, people in the general pulmonary community may not be familiar with it. So I'll share that with you. And so Dr. Evan Chu had written a very nice review article on the pathogenesis of OSA and how it may be used to personalized treatments, and reviewed in this model where you have an exposure, a modifier, and an outcome. And in this case, our outcome is whether somebody gets or doesn't get sleep apnea, and exposure is really the anatomy, the risk factor for sleep apnea. And so if somebody has anatomy that is predisposing you to an open airway, so you have a musculoskeletal structure with a fairly large jaw that's protruded, you don't have a flat arch palate, you don't have a large neck, you don't have a lot of obesity, you're going to have an open airway. And it doesn't really matter what else happens, you're not going to develop sleep apnea. On the other hand, if you're an individual who has, for example, Down syndrome, has multiple risk factors for sleep apnea that are anatomical, so retrognathia, microglossia, pharyngeal muscle flaccidity, you're going to have sleep apnea no matter what happens in between. But turns out that there's a whole lot of patients with sleep apnea who have something in between these two extremes. That's what we call a vulnerable airway. And whether these patients develop sleep apnea or not tends to depend on these physiological traits, like these physiological characteristics that they have. And these characteristics are called loop gain, muscle responsiveness, arousal threshold. And depending on what combination of those things you have, you might develop sleep apnea or might be protected from sleep apnea. And so the focus of today's talk is really going to be around these physiological mechanisms and how we might utilize them to improve patient outcomes. So how do we measure these physiological traits? And so as ICU docs, you know that probably the best predictors of something happening are dynamic metrics. So if you're trying to see if somebody is volume responsive, you're going to do a passive Lagrave maneuver, or you're going to change their tidal volume on the ventilator to assess whether they're volume responsive. And so sleep apnea is really no different. And so the way that we generally measure these physiological traits is that we instrument patients with electromyography on their tongue, a epiglottic catheter, a pneumatochometer, and eventually the patients fall asleep. And then what we do is we titrate them to an optimal CPAP level where the sleep apnea goes away. And then we sort of drop that level by 1 centimeter or 2 centimeters or 3 centimeters and see what the body does as a response to the drop in flow and to increasing airway obstruction. And we can measure how frequently do arousals occur, what happens to the flow, what happens to the muscle activity, and that can give us a sense of what these traits are. And so let's talk a little bit about the first of these mechanisms. And the first one is something called upper airway muscle responsiveness. This is probably the most intuitive one. And so what you see here on the x-axis is something called ventilatory drive, which is really epiglottic pressure. So the more negative the number, the higher the drive to breathe that the brain is sending to the body. And then the y-axis is genioglossus muscle activity, which is essentially what we measure with an EMG. And you see a response to these CPAP drops, these are dozens of them, in 2 different individuals. So the first individual is the blue individual, and you can see that as the ventilator drive increases, as you go along the axis all the way to the right, you see that the muscle activity also increases, which is what you would make sense. This is what you would want, right? On the other hand, you have an individual with poor muscle response, where it doesn't really matter what the drive is. The muscle is what it is. It's not really moving. It's not increasing activity. And so you can imagine that if you have two people with similar anatomical compromise, and they both fall asleep, and one person is blue, one person is red, the red person is going to end up developing sleep apnea as opposed to the blue person. All right. So the next trait is something called loop gain or high loop gain. And loop gain refers to, the loop is a respiratory control loop. And so it's the caudal pons and the rostral medulla where the respiratory centers live. It includes the descending motor pathways to the diaphragm, to the upper airway dilator muscles, and also includes all of your chemoreceptors. And so if somebody has high loop gain, that system is very sensitive to changes to CO2 or O2. Somebody has low loop gain, it doesn't respond as vigorously. And so you can have, again, you can have two people that have very different ventilatory control stabilities. So for example, you have an individual that's shown here. On the y-axis, you have flow. On the x-axis, you have time. And so that patient has sleep apnea. You've titrated them to CPAP to the optimal pressure. So the airway's open, they're breathing very nicely. And then what you can do is you can reduce the pressure by a couple of centimeters. And what will happen, the ventilation will decline. Eventually, the body will try to compensate. The ventilation will go back up, but it will never reach the normal level because the airway is still obstructed because you took away some of that pressure in the CPAP. And then what you can do is you can put the pressure back up, open the airway, and see what the body does. And so in this person, you can see that ventilation transiently goes up, settles down, and goes back to normal. But this person has a very different ventilatory response. This person, to the same stimulus, to the same reduction in CPAP pressure, will have a very vigorous response to ventilation, where the ventilation will go 2 to 3 to 4 times of what it normally would be for that drive. And you might say, well, that's pretty good, Andrey. What's the problem with that? Why would that be a problem? I mean, that's what you really want to happen. Well, one of the things that happens during these hyperventilatory periods is they have reductions in CO2. And as you have reductions in CO2, which is the major driver, not only to the diaphragm, but also to the upper airway dilator muscles, including the genioglossus, you will have decreased upper airway muscle tone and airway obstruction. And these individuals will cycle through these periods of hyperpnea and hypopnea, hyperpnea, and apnea that is obstructive in nature because there's air obstruction, really due to how sensitive their system is. All right. And so the last player in the game is arousal threshold. And arousals have sort of a dual role in sleep apnea. So the primary role that we all were familiar with from medical school is the fact that arousals are a lifesaver for people with severe sleep apnea. So if you have an apnea, you have a closed glottis, you're trying to breathe, the CO2 increases, the PO2 drops, and you can't improve your oxygenation, your O2 keeps dropping. Eventually, the brain will say, I'm asphyxiating, so I got to wake up. So the brain wakes up, there is increased drive to the upper airway and motor muscles, the airway opens, the airflow resumes, and you sort of settle out again. So in this case, for example, for somebody who has physiology like obesity hypoventilation syndrome, this is really a lifesaver. If those people didn't wake up, they would asphyxiate and die in code. But then there's another sort of different part of arousals. They can actually destabilize breathing. And so if somebody is easily arousable, they have less sleep continuity. If they have less sleep continuity, they don't get into these more deeper layers of stable sleep. And if they don't do that, then anytime they arouse, they'll have these excessive changes in CO2 with these hyperventilatory breaths. And now it's similar to this loop gain mechanism where you have excessive reduction in CO2, cycles with decreased upper airway muscle tone, and repeated cycles of sleep apnea. So arousals have a twofold role in sleep apnea. They can be life-saving or they can actually induce the disorder. All right. And so how do these things sort of come together to cause sleep apnea, and what do they look like in patients? And so up until recently, it's been really hard to do that because you can imagine to do a study on a clinical population of people coming in the sleep center where you're going to put like a needle in their tongue and you put a esophageal catheter in their throat, you put a mask on their face, and you're going to ask thousands of people to sleep. That's pretty hard to do, almost impossible. But one of the new technologies that has been developed in the last 7 or 8 years is ability to actually measure that from clinical polysomnography. And so this is a picture of Scott Sands. And the reason why I have it here is because he developed this method where he actually figured out that each of these apneas, each of these respiratory events are actually challenging the system, just like our CPAP crashes would do. If we were to decrease the pressure, that's essentially what you're doing. And so if you model the breathing system, arousals and oxygenation and flow, and you look for responses of the system to these hypopneas, you can actually figure out what is the arousability, what is this loop gain, what is this muscle compensation, which is pretty brilliant. And so, once you developed this method, then it became available for people to actually look at what happens clinically to patients. And so we started a collaboration with Dr. Yüksel Peker from Turkey, who does his work in Sweden, but also has an office in Pittsburgh. And he is one of those extraordinarily kind and encouraging people that is very happy to share data. And so he had this study that he completed, was a randomized controlled trial of CPAP therapy in people with heart disease. And he shared the data with us. And so what I wanted to show you, what we found in this data, is 2 individuals with the same AHI, Sven and Eric. The names are fictitious, but the people are real. And to show you what physiology might look like in these 2 people. And so if you look at upper airway anatomy, in this case, we can measure it also from the sleep study, and 0 to 100 essentially gives us an index of how close they are to perfect open airway breathing while they're sleeping, which is 100. So these both individuals have the same airway collapsibility, about 70%. But if you look at their ventilatory stability, you'll see that Sven has a much more sensitive ventilatory system than Eric. And then Eric is kind of a snoozer. He will sleep through a train going through his bedroom at night, and his O2 levels probably go down to the 60s before he wakes up. Whereas Sven will wake up pretty easily, pretty quickly. And so also their muscle compensation is different. So now you can start to see is that you have 2 people with presumably the same disease, the same AHI, but may have very different reasons for why they have it. So maybe we can take advantage of those differences. And so what do these people look like on a sleep study? And so if you look at the sleep study for these people, so Sven, which is the low arousal threshold person, will have very frequent events that are relatively short and will have a lot of arousal. So these green little bars represent an arousal from an EEG signal. These purple bars represent hypopneas in the flow signal, and the SpO2 is the red line. And so you see that having frequent events, not a lot of desaturations, but a lot of waking up. On the other hand, Eric will have longer events. They'll be deeper. There'll be more desaturation. They'll have less frequent arousals. And so you can imagine these people actually might look different on the sleep study and even clinically. And so we actually asked that question. This data hasn't been published yet, but we're asked the question, so what do these people look like compared to each other, and why are they so different? So these are about 500 people from another clinical trial called Apples. I'll talk about that group in a little bit, but essentially individuals who were referred for sleep apnea treatment with CPAP versus sham CPAP, look at neurocognition. And we basically compared the clinical characteristics between individuals with low arousal threshold and high arousal threshold. And so the people with high arousal threshold tended to be a little bit older, 4 years older. They tended to be more male. So females tended to be more prevalent among the group with low arousal threshold. What did their sleep apnea look like? So the severity of sleep apnea in general for people with low arousal threshold was less severe. So by a lot. So about 30 times per hour was the difference. The degree of hypoxia that they had was also much greater than the degree of hypoxia in people with low arousal threshold. But despite these differences in frequency of breathing disturbances and the hypoxia, what we call something a wake sleep balance, or the depth of sleep, was very similar. So actually the sleep was just as disturbed in the people with low arousal threshold versus the high arousal threshold. And then if you look at symptoms, you'll notice that people with low arousal threshold are just as sleepy as people with a high arousal threshold, despite having this huge difference in sleep apnea severity. But they tend to have more insomnia, more unrested feeling during the day, and more fatigue. And so it's a different phenotype of sleep apnea. All right, so now that we know that these different traits can lead to sleep apnea in different ways, they may look different in each individual, do they predict therapy outcomes? Do they do anything that's useful? And so in the last 5 years, there's actually been a good amount of work that's looked at these traits in non-PAP therapies, because people are interested. PAP is really hard to tolerate, so we need to find how do we better treat people with non-PAP therapies. And so how do we identify people who respond to it and who don't? And so it turns out that if you, on the left side, you'll see oral appliance, which is this beautifully modeled by a nice hand that's white. And it shows that if you have high arousal threshold, you have low loop gain, and you have moderate collapsibility, you're probably going to respond to this therapy. On the other hand, what we see down below is something called a hypoglossal nerve stimulator, which is kind of like the pacemaker for your tongue, is that if you have high loop gain and low arousal threshold, you're going to fail this therapy, which kind of makes sense because with neurostimulator, you're addressing anatomical compromise or muscle responsiveness, and you're not addressing these other causes of sleep apnea, like loop gain and arousability. And so similarly, some data has been shown to show that, oxygen therapy can actually be useful in some people. But the reality is that most people with sleep apnea get CPAP and not other treatments. So 80% of prescriptions for treatment of sleep apnea initially include CPAP. And this will change. As you may have heard, that there was a study that just came out in New England Journal of Medicine looking at GLP-1 drugs that showed a marked improvement in sleep apnea severity. And so these pies will look very different a year or two from now, so stay tuned. But for now, PAP therapy is still king. And so what we wanted to do is try to understand, okay, what if we look at this arousability? It seems like it's a pretty big difference between two people who present with the same AHI. Does that matter? And what we thought about is that if you're easily arousable, and I put a mask on your face, you might have a harder time adhering to CPAP therapy. You might rip it off more. You might not have the ability to tolerate the pressure. Is that true? And so it was amazing to work with Clark because he already had a data set that was ready to go. He did a clinical trial of CPAP therapy in people with stroke. And so we tested this hypothesis, and what we found was that actually, yes, the higher the arousal threshold, the more likely you are to use CPAP. But also, the more muscle compensation you have, the more vigorously your tongue moves to a stimulus of CO2, the less likely you are to adhere. And this was controlling for a bunch of characteristics that we know are important for adherence, like chronic pain, activity, age, sex, disability, et cetera. And the effect sizes were pretty large. So for like a standard deviation change in arousal threshold, there was almost a 3-hour change in use. And this was pretty remarkable to us and exciting. And we sort of know that usually your initial exploratory data tends to overestimate effect sizes. So we wanted to validate this. And we went to look at a different study. So this is a population of people with coronary artery disease who ended up getting CPAP therapy. And this is from that randomized clinical trial that I mentioned before of Swedish participants. And it turns out that if you create a phenotype of people with low arousal threshold and extremes of this muscle compensation, your CPAP therapy outcomes are very different. So if you're in that red group that have a low arousal threshold and extremes of muscle compensation, your CPAP usage is about an hour, hour and a half lower over 2 years compared to those who don't have it. All right. And so we know that maybe arousal threshold is relevant for adherence. Do these traits influence how well CPAP works for our sleep apnea? And so we used both of the same data sets to see whether these other traits are relevant. And Aaron, our stellar fellow in sleep medicine, is actually doing research on this. And so we've looked at 2 different cohorts, 2 different completed clinical trials. And what we found is that if you have this ventilatory instability, so if you're in the highest quartile of this loop gain metric, you are either at somewhere between 3 to 7 times the higher risk of having a residual AHI of greater than 10, so having residual sleep apnea. So again, physiologic traits may be relevant to how sleep apnea is treated with CPAP, how well. And then the last question we wanted to ask, which was virtually no data out there, is, do these traits influence how well you treat, I don't know, neurocognition, or how well you treat blood pressure with it? And so last year, there was a pilot study that was published by Chris Schmickel from UCSD. And what they did is they looked at a completed clinical trial of CPAP versus oxygen versus healthy lifestyle intervention. And they were able to get these traits from these individuals for loop gain. And what they saw was that depending on what your ventilatory stability was, your response to CPAP in terms of blood pressure was very different, especially as your loop gain increased, the benefit from CPAP became greater and greater, which actually is sort of one way to think about of trying to resolve this heterogeneity of sleep apnea, because even though we know that treating sleep apnea with CPAP improves blood pressure, the effect size is very small. It's about 2 millimeters of mercury. If you think about it, like ACE inhibitor, that's like 6 to 8 millimeters of mercury. And so why is that? And so this may be one of the reasons, because we're not treating the right individuals with it. And so what we wanted to do is actually examine the impact or the relationship between these traits and CPAP's influence on neurocognition. So this is a study published by Clete Kushida from Stanford, and they looked at 6 months of CPAP therapy versus sham therapy. And that's amazing. I commend them for doing that. That's a hard study to do, but and they looked at neurocognitive outcomes. So they looked at attention, memory and learning, executive function, and the bottom line was that CPAP did not improve any of those things. They did some subgroup analyses that show maybe for people with most severe sleep apnea for 2 months, they had some benefit that disappeared in terms of executive function, and the relationship is complex. And so we thought, well, how can we try to untangle this complexity? And so going back to our arousal threshold idea is that, well, if you are harder to arouse and perhaps you're more sleepy, perhaps you have a more cognitive burden from sleep apnea, maybe you are more likely to respond to CPAP therapy versus if you're easily arousable. On the other hand, if you are easily arousable, maybe you're going to have a harder time adhering to therapy, so you won't get the benefit anyway. And so what we did was we actually did a secondary analysis of a randomized clinical trial and looked at executive function, which is really our ability to plan, inhibit our actions, and follow complex directions. And so if you look at executive function, this is a sustained working memory test. What we saw is that depending on your arousal threshold, which is on the x-axis, standardized, so 0 meaning average arousal threshold, your response to CPAP therapy differs. So the higher the arousal threshold, the more difficult it is for you to wake up from respiratory stimulus, the more likely you are to benefit from CPAP therapy. And you may say, I don't know, what does that mean? What is the sustained working memory test 0.02 mean? I don't know. But really what that means is that for every standard deviation of arousal threshold change, you get about 75 milligrams of caffeine effect on outcomes. So that's not bad. I would do it. And so the other nice thing about this study was that they did multiple outcomes for the same concept. So in this case, they looked at executive function in a different way, and we actually saw a very similar signal. And so the effect size was also pretty significant. It was about 50% of the difference between people who have sleep apnea and who don't in terms of this particular test. And so to summarize, what we've seen and identified is that these non-anatomical traits may impact effectiveness of CPAP therapy in sleep apnea. And so here are some examples. So arousability and muscle compensation may be important for adherence, loop gain for efficacy, and loop gain for blood pressure and neurocognition is arousal threshold. So now we're having some idea that, gosh, maybe we can tailor therapy based on these traits. But there's a lot of limitations of these data. First of all, it's retrospective, and literature is littered, not a good word choice at this point in time. Literature is full of studies that are retrospective, promising markers that turn out to be nothing. And so really all these things have to be validated prospectively. In addition, many of the patient-oriented outcomes that we're interested in for our patients are missing from these clinical trials because they're focused on very narrow degree of outcomes, for example, neurocognition or just blood pressure. And similarly for adherence, adherence is, as you guys all know, whether it's CPAP or inhalers or anything else, it's a complex behavior. It involves a lot of psychological variables, a lot of social determinants, and really don't know what the mechanisms are. And so one of the things that we wanted to do is to study this prospectively and assess all these other factors that may be relevant for outcomes. And so we did this through a K23 project that looked at CPAP effectiveness, including CPAP adherence, through the lens of a biopsychosocial model. And so we know that there's a bunch of variables like self-efficacy, outcome expectancy, whether someone is ready or not ready for therapy, that's going to influence adherence. There's a bunch of social factors that we know are important, such as partner support, health literacy. What is someone's ethnicity or race and their resources? And also some biological features, so like sleepiness. Do they have a mask leak? And, are OSA trait signals that we're seeing, is that just, a confounding phenomenon with one of these other variables, or are they real? And so to answer that question, we designed or almost completed a study of something called NICE-PAP. We're recruiting 267 people who are newly diagnosed with sleep apnea at the Yale Centers for Sleep Medicine. And we are, thank you, Naya, Yuri, and Munib, we're at 257 out of 267, so we're almost there. And what we're doing is we are following them for 6 months. We're measuring every day of their CPAP therapy usage, every day of their residual AHI. We're assessing all these psychological and social adherence determinants. And we're getting these traits, but having them do a in-home sleep study. And what we're going to do is, for the first time, prospectively assess whether these traits are independently predictive of adherence, symptoms, and neurocognition and quality of life. All right, so we are about 40 minutes. I think we have a little bit of time for a couple of more slides, and then I'll stop. And so, that's good. So that will help us predict who might respond to therapy, right? But the holy grail is to actually tailor specific therapy to each individual based on unique characteristics. And it turns out that, there are some treatments that address each of these different components. So if you have an anatomical problem, CPAP will do it, weight loss will do it, maybe positional therapy will do it. If your muscles are not working the way they should, there's upper airway muscle training like PT for your upper airway. And there are products out there that are trying to address this. There's tongue stimulation, which is a hypoglossal nerve stimulation. And now there are medicines, there are drugs that address upper airway muscle responsiveness that likely will be approved by the FDA within the next couple of years. We can reduce the ventilatory sensitivity by giving people oxygen, reducing their CO2 fluctuations, using drugs like acetazolamide, which are carbonic anhydrase inhibitors. And we can address hypnotics. We can address arousal threshold with hypnotics or possibly even cognitive behavioral therapy. But in order for that to be the case, we don't really have the data. And so it's all conceptually is very nice, but it's been a few years now where we've been sort of talking about, okay, so here's how we might do it, but there's really no studies showing that this approach might work. And so we really need to look and see, can we target modification-based traits with treatments? And are these traits more phenotypes? Are they just biomarkers of what's happening with patients? Or is it really a mechanism of disease that if you change it, you're going to change the disease? And how do you select people for OSA treatment using these traits, and what are the cutoffs? And so to answer some of these questions, at least in terms of the arousal threshold, we had proposed a randomized clinical trial that's mechanistic. We call it CALM OSA. Has to be calm, has to be nice. And what we're going to do is we're actually going to change arousal threshold in individuals with sleep apnea. And we're going to see whether changing arousal threshold in people with sleep apnea influences outcomes such as adherence, cardiovascular disease markers, or neurocognition. And while we do that, we're going to actually look at the mechanisms of how this might occur. Is it because we change sleep duration, the depth? People are able to tolerate high CPAP levels, like less claustrophobia. And then for other outcomes, is it because they have less hypoxia, they have better sleep depth, less sleepiness? Are there changes in their neuroaxonal damage biomarkers? And so the way we'll do that is like I said, this randomized clinical trial. We have about 250 people. They're going to all undergo a sleep study. We'll find out, we'll poke the bear first time around. We'll find out what their arousal threshold is, and then we'll randomize them equally into each arm, where people will get something called exopiclone, which is Lunesta, or like a long-acting Ambien, or placebo. We'll measure those traits again, and then we'll randomize them to CPAP versus CPAP with placebo or CPAP with exopiclone, and follow them for 3 months and measure all the outcomes I've mentioned. So in this way, we're going to start having some data whether you can actually target patients based on their arousability. All right, so I'm going to just finish up with a little bit of how we can put this together. And so I think one of the key things for creating more precise ways of managing patients, I don't want to call them personalized because we're not quite there yet, is to develop these prediction tools that tell you who's going to respond to what and why. And so it would be foolish for me to say that the success of CPAP is really only based on the physiology. We know that there are social characteristics, physiological and clinical characteristics. And so if we created models, which we can from, hopefully from this K23 data, we'd incorporate important factors such as sleep literacy, peer support, the psychological factors, clinical factors, and these physiological factors to help understand how likely is somebody to succeed with therapy and why. And if we know those two, so if we have a pretty good clinical prediction tool up front before the patient ever experiences CPAP, all right, we can help triage patients to the right arm. So if somebody has a high rate of success, they're likely just going to get PAP and routine care and will do quite well. If they're at risk for failing CPAP, then we can identify what are these risk determinants. Many of them are modifiable. And through the decision-making process, we can decide, do we pursue precision PAP? Or we say if they're going to have a hard time with adherence, we're going to have a better sense of why is that? Because they're ambivalent to treatment, because they have insomnia, because they have easy arousability, and there are targets for each of these items. Similarly, if they're not going to do well with CPAP because CPAP is not going to reduce their OSA severity very well, we can have treatments for this, including carbonic anhydrase inhibitors, oxygen, or position therapy. Now, if they're not going to respond to CPAP because they're non-sleepy, they don't have a lot of hypoxia, they have easy arousability, that's a tough one. I don't have an answer to that. That's still yet to be determined. They're still working on this. And if they really prefer a non-PAP therapy, there are all these other options that I'll go over in a little bit. So this is a way that I'm thinking that we already can start doing this treatment decision-making that is more precise than the way we do it now, incorporating the data that we're going to get from these studies. All right. So the couple of take-home points is that these physiological traits are relevant for pathogenesis, but also treatment therapy success. They may actually help us identify who responds to CPAP and who doesn't, for what reason. And so before I finish up, just want to share a bit of overview of what are some of the other areas of research that we're focused on now. So one of the questions that's relevant to the field is that, the way we measure adherence is we understand, how many hours per night the person wears their CPAP mask, but we have no idea whether they're sleeping or not. And so are they, just because I'm wearing a CPAP mask for 6 hours, am I benefiting for over those 6 hours? And so we're working with some colleagues at NYU in developing algorithms to predict whether someone is sleeping or not, simply from the CPAP flow channel. And so we can understand whether someone's sleeping or not when they're wearing a device. One of the other big questions that's popping up in the field is whether CPAP or GLP-1s are better for OSA. That's an unanswered question. We know that GLP-1s can treat OSA and can help reduce the need for CPAP, but should we be treating patients with CPAP or GLPs first? We don't know that. And so there are studies now being planned through the PCORI that Clar and I are participating. Clar is going to be the site PI to help answer that question. So stay tuned for that. Some of the other things that we're looking at is trying to understand what might be some other contributors to sleep apnea. And Dr. Brian Koo has been focused on restless leg syndrome and periodic movements of sleep most of his career. And through observations, through him reading sleep studies and us doing them together and me reviewing it with him as a fellow, we noticed that, gosh, sometimes there's decreased flow and apneas following periodic movements of sleep. And periodic movements of sleep are these little leg jerks that people have at night, and we don't really do anything with them. We sort of just monitor them. Usually we think, oh, they'll go away if you treat the sleep apnea. But it turns out that this flow reduction is real, and people actually can develop hypopnea after these leg movements. And so do legs actually contribute to genesis of sleep apnea in some people? And it turns out that these periodic limb movements are associated with increase of heart rate, increases of blood pressure, sympathetic activity. And with Clar and Brian Koo and others, what we've done is shown that these periodic movements of sleep are actually independent predictors for cardiovascular disease. So now we're looking at other markers of sleep disturbance that may help predict and treat outcomes of disordered sleep breathing. And so lastly, I want to finish up with what we are able and not able to do at our sleep center for sleep apnea. And so CPAP therapy has been sort of the mainstay of treatment for 40 years now. And that has been sort of the main therapy that I knew about when I was starting fellowship and thinking about medicine. And so since that time, we've learned that oral appliances or these mandibular medicine devices can treat sleep apnea. And believe it or not, healthy lifestyles, exercise, diet, weight loss, along with improve airway muscle stability can actually reduce sleep apnea severity and eliminate need for CPAP in some patients. But with time, we're noticing that we're actually in our sleep center, we now can offer patients GLP-1 therapy for treatment of their obesity and OSA. In the last couple of years, we've actually developed a program that includes hypoglossal nerve stimulation, so a pacemaker for the tongue. Positional therapy, there are specific devices that are evidence-based to reduce sleep apnea severity. And we have data that in certain patients, oxygen, medications, and neurostimulation of the tongue can be helpful. And so just to let you know that CPAP is not the only option for your patients. So if you have a patient you see in clinic and you wanted to have them treated, and if they're intolerant of CPAP, that's not the only thing that's available, although it is still a #1 treatment prescribed. And so the idea is that at least with the next few years, we can probably start incorporating these endotypes and phenotypes in the clinical decision-making. And in the AMP clinic that I run, I actually am starting to do that and using some of these phenotypes and endotypes to help me understand what would be the treatment selection for some individuals. So I will stop here so in case people have questions, and I want to acknowledge people that are near and dear to my heart. And so all the way on the left, you see my mother, who's a physician. She's a pediatric intensivist, and she still does work. She's 72 years old, and she still does nights. And that's my son, Yuri, who's a fencer, my daughter, Lida, and my wife, who has been putting up with my shenanigans for the last 10 years, supporting me and taking care of the kids. And my dog, Tanner, who is a sign of, that helps me understand that nothing, at least physically, in life is permanent. And destroys almost anything in sight. And but also has taught me some persistence lessons in my life. So I'll stop here and be happy to take your questions.
Thank you, Andrey. That was fantastic. And we're going to open it up for questions. And while we're waiting for folks to formulate some questions, both online and the audience, I'll get started. And I think I really like how you brought together this sort of dashboard approach that we're just starting to implement to help instead of like your title, instead of CPAP for all, and then dealing with CPAP failures and salvage therapy, really targeting therapy to underlying, and that's the dream, I think, in a lot of different fields. And I think one of the things that has really brought that closer to reality, as your talk so nicely demonstrated, is that we can derive these traits from standard polysomnography and not have to do these very aggressive, which has been a boon for our field. The question that I was going to start with was sort of related to the first two patients that inspired you to go. And it was not lost on me that one was male and one was female. And the male tolerated CPAP, loved it, and the female did not. And it sounded like you shared some preliminary data looking at some sex differences. And Christine Wan has also done some, I think, similar work. I was wondering if you could talk a little bit, maybe both of you, about some of the sex differences data.
Yeah, great. Thank you, Clara. That's a great question. And Christine, actually, to advertise, Christine did a great paper as published in Sleep in 2021 or 22, looking at sex differences in terms of sleep apnea pathogenesis. And they looked at it like about 2,000 people from the MESA cohort. And what they saw was that some of the sex differences in sleep apnea are explained not just by the collapsibility, but also by arousability. So the arousal threshold was markedly different between the two groups. And so I don't know whether that is due to inherent differences or whether that is due to hormonal changes between age groups. So Christine, maybe you can comment on that. But one of the things that we do know is that women with sleep apnea tend to present a little bit differently than men with sleep apnea. They tend to present more with fatigue and insomnia symptoms. And these repeated middle of the night awakenings could very well be related to the easy arousability. And so that study has not been done, but I think it really, we sort of keep making inferences about that being the case, but it'd be good to show that it actually is the case. So Christine, welcome any comments that you have.
Oh, no, I think, I mean, congratulations on this great talk, Andre, but I think I agree with you. I think it's sleep apnea, and that's sort of my clinical gestalt belief and research is that sleep apnea may manifest differently in women and men. And I think any further research that we do in this area, I think needs to recognize that and sort of
Yeah.
look for sex differences. So I appreciate that you do acknowledge that because you're right. It's gonna, you know, you might find very different outcomes.
Yeah, and that's great. Thank you. And that's actually been a priority for our K23 project is that most sleep apnea cohorts are male dominant. It's like mostly white dudes, 67 to 80%. And do we really need to make decisions for the entire population based on that? And so we were very fortunate with Munib and Naya. They recruited 50% female cohort, which is going to be great to look at.
Great talk, Andre, as always. My question relates to comorbidities.
Yeah.
Sort of a two-part question. One is, do the different profiles of sleep apnea with the different arousal thresholds and other profiles that you mentioned still hold up when people have comorbidities such as COPD or other heart disease, et cetera? And part two of that question is, how are you going to handle that in your clinical trials of the people you're recruiting into the, into the future clinical trials? How will that be addressed?
Absolutely. So great question. I think comorbidities are an inherent part of sleep apnea pathogenesis. For example, this whole concept of loop gain is really derived from people with Cheyne-Stokes respiration. So people with Cheyne-Stokes respiration have very sensitive ventilatory drive to CO2, and that's why they have the Cheyne-Stokes. And so this is really so high loop gain is sort of the milder version of that physiology. And so people with cardiac disease, including atrial fibrillation, diastolic heart failure, I should say, HFpEF, will have higher loop gains. And so that's an inherent piece. The comorbidity piece is inherent manifestation of the physiology is inherent manifestation of the comorbidity. So for example, also with COPD, it turns out that some of the individuals who have the OSA COPD overlap syndrome or co-occurrence, I could say, I don't want to call it a syndrome yet, but they tend to have lower arousal thresholds than their brethren of the same BMI and without the COPD. So I think that it's definitely related to comorbidities, and those people will be included in these clinical trials.
Are you going to control for that in any way?
Yeah, so I mean, we are stratifying our randomization by arousability, but also by age. And so the idea is that if we use those two stratifications, we're hoping that the rest of the comorbidities will go along with that. Part of, majority of people who present to our sleep center, maybe, 10, 15% will end up having COPD in general. So it's not a huge proportion, but we will not exclude them from the cohort. Yeah.
Yes, Andrey, so many of sleep apnea talks, we see these slides that show the obesity epidemic.
Yes.
And then the sleep apnea epidemic, and there's a correlation suggested by the two of them. And I'm wondering, as we start to break this syndrome down by phenotypes, is the type of sleep apnea that we're seeing that's epidemic solely related to the obesity, or are there other factors that might be contributing to the other phenotypes becoming more common?
I see. Interesting. So all right. So, I mean, I think the step one, the first good step is that we're starting to recognize it's not just obesity, right? Because I see plenty of patients who do not have obesity and have very severe sleep apnea. So in terms of what are the contributors to those endotypes that are, what is the basis for those? I'm not sure, to be honest with you. I don't think we've looked at that. So there are some genes that are related to high loop gain, for example, that people have looked at. But the basic science, like the pre-endotype basic science stuff, hasn't been done at all.
This might be interesting to ask. Are there some sort of environmental or, like Carly's saying, comorbidity factors that are increasing aside from obesity?
Exactly. Absolutely. And I think what will happen with the GLP drugs is that you'll reduce the contribution of obesity and anatomy to sleep apnea, and you got to unmask a whole bunch of other things that contribute to OSA. So in fact, I think these traits will become more relevant with the GLP-1 inhibitors to help address people's sleep apnea, because you're going to eliminate at least anatomy in part, and then you're going to be left over with other contributors. Yeah, great. Thanks, Mark.
All right, we have time for a few more questions, and there are a couple in the chat. The first one is from Dr. Rue.
Hi, Francois.
Wonderful talk. Does the arousal threshold change after menopause?
Oh, that's a great question. I will be able to answer that question after 10 more individuals enrolled in our study, I think. I think, the trouble with answering that question is that most cohorts of community women tend to enroll women in older age, so like postmenopausally. And so part of that was to sort of make them match up more with men, right? Because like the sleep apnea pathogenesis is very different in women before menopause versus postmenopause. And so I don't know if we have an answer to that question. I don't know, Christine, when you looked at MESA, I think MESA is mostly women, older women, right? And so this is another example of how we were creating our data sets, is like trying to match women to men, by picking older women to be in those cohorts, which is tough. So I don't have an answer to that. I don't know whether the menopause plays a role. I would imagine the menopause will play a role in loop gain because of progesterone. We know that progesterone is a respiratory stimulant. And so that probably will play a role.
Francois knows this, but obviously the rates of sleep apnea go up dramatically post-menopause, and it's may in part be related to some of these physiologic traits, but we also know that body weight distribution changes post-menopause, which predisposes to upper airway collapse. There's a couple other quick questions. One is in the tirzepatide study that was published in the New England Journal of Medicine, are they looking at endotypes and phenotypes?
They are looking at endotypes and phenotypes, and so that paper I'm sure will be published in the next few months.
So it's going to be interesting to see if it's not just collapsibility, but weight loss. Does it affect some of these?
So it's interesting. There's, the first secondary analysis of that trial already has been published, looking at something called hypoxic burden as opposed to AHI. And hypoxic burden is essentially a metric that relates to how much hypoxemia or truly hypoxemia, Dr. Matthew, is Dr. Matthew, hypoxemic burden should be called hypoxemic burden, not hypoxic burden. But it's basically a hypoxemic burden that's related to the sleep apnea events only, not to COPD or anything else. And what they're seeing is that the tirzepatide actually, the degree of change of hypoxemic burden is much greater than the degree of change in AHI for these individuals. So hypoxia is much improved.
All right. We are going to unmute for a final question. Dr. Krieger wanted to ask a question. Mayor, go ahead if you can.
Yeah. So there's another important difference between men and women. And women with sleep apnea, as you mentioned, they're much more likely to have insomnia, but they're way more likely to be on antidepressants. And they're way more likely to be treated for depression. And how are you going to look at the impact of these drugs?
So in our study, we're going to monitor that. We'll use that as a controlling variable. So we actually will see whether, women and men with sleep apnea actually have higher prescription rates of SSRIs. So that's an observational study. In the clinical trial study, the reason why I imagine you're bringing this up is because the SSRIs and SNRIs do have some activity on the upper airway tone. And so, especially for the SNRIs, they can improve upper airway tone in non-REM sleep. And so that may influence physiology.
And symptoms, of course. Yeah, and they also will decrease rapid eye movement sleep.
Yeah, right. So we do measure them, and so we'll be able to account for them. Yep, that's a great question, Mayor.
And caffeine intake. Men with sleep apnea are much more likely to drink a lot more caffeine than females.
Oh, interesting. So actually, that's a great question. we looked at this question in the Apples data set, and there was no difference between men and women. So if you look at a paper by Steve Baldessari, it turned out that in that cohort, at least, there was not that much of a difference, but we will measure those things as well. Thank you, Mayor. Those are really helpful comments.
One final point, and
Yeah,
then
sure.
we're going to wrap up. Thank you for an awesome discussion. You very nicely talked about the loop gain trait in particular, and pointed out how that can be a cause of obstructive sleep apnea. But most of the audience will relate that to Cheyne-Stokes respiration that
absolutely.
we see in heart failure patients in the ICU. And that's a prominent mechanism for that. And we have a new therapy that we're exploring bringing to the center. I was wondering, called Remedy. I was wondering if you could talk a little bit about that.
Yeah, sure. Thank you, Clara. So one of the challenges of treating central sleep apnea is that people oftentimes are very intolerant of PAP, and PAP generally can make sleep apnea, central sleep apnea, worse. We used to have this therapy, we still do have this therapy called adaptive servo ventilation. But the challenge with that therapy is that there's one study that showed that maybe mortality is higher in people with severely depressed ejection fraction. And so it turns out that central sleep apnea is really hard to manage in people with heart failure. And so this remedy therapy that you're mentioning, Clara, is something called a phrenic nerve stimulator. And it's implanted by a cardiologist, like an AP doc. And essentially it sort of sits next to a phrenic nerve and will stimulate the diaphragm to contract during essential apnea, eliminating central events. And so we're going to be piloting that program within the next year, so stay tuned for another potential therapy for sleep apnea patients. So you could potentially have people with a pacemaker for the tongue, a pacemaker for the diaphragm, all at one shot. And the heart. Hopefully not.
Hopefully not all.
Okay. All right. Well, thank you very much, everybody. Appreciate it.